My name is Dr. Prithvi Patel, MCH Cvts at UNMICRC Institute of Cardiology at Ahmedabad. Today we will discuss about pulmonary function test. We will decode the lungs. So what is PFT? Pulmonary function test is done to determine how well is your lung, and they determine how much air goes in and out of your lungs, how much air goes from your lungs to your blood, and how well your lung works during the exercise. Our learning objectives for these slides will be to describe the clinical indication for pulmonary function test, understand the physiology of the core pulmonary function test like spirometry, lung volumes, and diffuse DLCO. To apply an organized approach to interpret the pulmonary function test, and to identify obstructive, restrictive, and mixed pulmonary vascular pattern of abnormality on pulmonary function testing. So indication for PFT, why we do PFT? We do it to evaluate pulmonary presence of impairment, type of pulmonary dysfunction, quantification of impairment in known disease, monitor the progression of known disease, monitor the treatment response of known disease, and as a preoperative assessment to assess the risk of post-operative complication and operability of the surgery, or for lung cases, tolerance for lung resection and resectability. So we go back to physiology. There are 4 volumes and 4 capacities in this test. This is mainly showing first one is tidal volume, the volume of air entering nose or mouth per breath, that is normal in adult individual, it is 500 ml. Then residual volume is the volume of air left in the lungs after maximum force expiration, that is residual volume. Then expiratory reserve volume, the volume of air that is expelled from the lung during a maximum force expiration that starts at the end of normal tidal expiration, that is 1.5 liter in normal adult. And inspiratory reserve volume, IRV, the volume of air that is inhaled into the lungs during the maximum force inspiration starting at the end of the normal tidal inspiration, that is 2.5 liters. Then capacities, we have 4 capacities. Functional residual capacity, that means the volume of air remaining in the lungs at the end of normal tidal expiration, that is 3 liter. Inspiratory capacity, the volume of air that is inhaled into the lungs during a maximal force inspiration effort that begins at the end of the normal tidal expiration. The VT is tidal volume plus IRV, inspiratory reserve volume, is equal to 3 liter. We will get the inspiratory capacity. And vital capacity. Vital capacity is the volume of air that is expelled from the lung during a maximal force expiration effort starting after a maximal force inspiration. It is 4.5 liters in normal individual. And total lung capacity means total volume of lung, the volume of air that is inhaled into the lung after a maximum inspiration effort, that is 5 to 6 liter. And all these capacities and volume are shown in this diagram. Note that red color zone is not calculated with the spirometry, it requires body plethysmography. So what are the tests included in the pulmonary function test? Mainly most common is spirometry. It says about how much air and how fast air we can inhale or expel. And then second is body plethysmography. It shows the volume. With this we can calculate the total lung volume by calculating the residual volume. And DLCO is diffuse capacity. It measures the gas exchange, how much oxygen is going from lungs to the blood, how effective is our lungs. And other testings are airway responsiveness, to various drugs to identify the asthma, and respiratory muscle strength testing. This is for neuromuscular disease causing respiratory distress. So in spirometry, important two things are important. One is FEV1, that is expelled force expiratory volume in the first second after breathe out as hard as long you can. So in normal individual, 80% of the air will be expelled from their lung in first second of the expiration. So for this you have to breathe normally, then breathe in as deeply as you can, and then breathe out as hard and as long you can. And this will be measured on the volume to time curve. This is force vital capacity. It includes the inspiratory reserve volume plus tidal volume plus expiratory reserve volume. So to measure this, we have to breathe normally, breathe in as deeply as you can, then breathe out as hard and as long as you can. So how to interpret pulmonary function test? Step 1 is confirm the patient demographic data, because it varies from person to person, and age, sex, race, ethnicity, height, all things matter. Everyone will have different values, but for this we have to take standards value, and we measure z-score plus 1.64 to minus 1.64. In between this will be considered normal. So defining obstruction with FEV1 to FVC ratio, fixed, like we consider 0.7 is cutoff, but sometimes there will be some false negative and false positive also near the 0.70, because some patient will have a body surface area and height and ethnicity small, but they will have normal according to their normal healthy individuals of their group of people. So we have to take a lower limit of normal. Step 2 is to test of adequate quality. The quality of our pulmonary function test should be good. How we will assess that? By acceptability and reproducibility of the test from same individual. So our test should be free from any artifacts like cough, glot closure, machine should be free from leak, and good start should be there, and good effort from the patient should be there while doing the spirometry. So these are the expiratory flow time curve. In first diagram we can see there is a nice curve in that 80% of the air is exhaled out in the first second, and it looks like acceptable spirogram. Then second is flow to volume curve. In that also it looks like acceptable, but in third and fourth shown at bottom are not good curves. First one is third one is showing variable effort and early termination, and fourth one is showing cough during the pulmonary function test. And reproducibility should be there. When patient is undergoing pulmonary function test, mainly spirometry, he can produce same graph during his 3 consecutive attempt, and if any variation is there in same person's 3 attempt, then it is considered as not acceptable. In this graph, first one A graph is showing non-reproducible test. Second one is showing reproducible test, almost similar graphs. Third one is also showing different graphs, so it is not non-reproducible, not accepted. And fourth one is showing same 3 attempts, 3 attempts showing same graph, so it is reproducible test. So step 3 is flow volume loops. So this is flow volume loops. It starts from the other end. It is lower part is inspiratory and upper part is expiratory. From away from the y-axis, it's a starting point. It goes towards the total lung capacity. It measures the vital capacity from right side, then below, then meet the y-axis, and then it goes up as a expiratory flow. So first one is A diagram is normal. B is showing a obstructive pattern. In that patient is lungs are trapped with the air, so it's not able to expel properly. And C diagram is showing restrictive disease. Overall loop is smaller compared to normal loop. Total capacity is reduced. And D diagram is showing extrathoracic airflow obstruction, and E is showing fixed airflow obstruction, that we'll learn in next slide. So spirometry flow volume loops detect the obstruction lesion in major airway. So this diagram here, first one is showing intrathoracic variable obstruction. That obstruction is in the thorax, and it will vary during the inspiration and expiration. During inspiration, because of negative pressure in the thoracic cavity, the obstruction will move away and it will precipitate during the expiration when we breathe out. So graph will be flattened during the expiration, which is upper part in the flow volume loops. Then second diagram is middle one. The middle diagram is showing extrathoracic variable obstruction. In that, the obstruction is precipitated during the inspiration because it is outside the thorax. So the negative pressure of thorax won't affect the extrathoracic obstruction. So here inspiration is obstructed, so lower part of flow volume loop is flattened. And last bottom diagram is showing fixed intra or extrathoracic. In that, both loop, expiratory and inspiratory, both loops are flattened. So obstruction is fixed. So this detects the obstructive lesion in the major airway, characterize the lesion. It can locate the lesion, whether it is extrathoracic or intrathoracic, and the behavior of lesion, whether it is fixed or variable during the rapid inspiration or expiration. The example of these lesions are variable intrathoracic lesion is due to tracheomalacia and intratracheal tumors. Variable extrathoracic lesion is due to vocal cord paralysis, goiter or tumor, and fixed intra or extrathoracic lesion are tracheal stenosis, surgical stricture, and mass compressing the trachea. Then step 4 in our interpretation of PFT with systemic approach. We will recognize the pattern and classify the severity of abnormality. So in obstructive disease, we will have a FEV1 to FVC ratio less than 0.7, and this disease include asthma. Asthma is a reversible obstructive disease, and COPD, which includes emphysema and chronic bronchitis, and bronchiolitis and bronchiectasis. Then in restrictive lung disease, we will have reduced or normal ratio of FEV1 to FVC, but lung volume will be reduced for sure. These include interstitial lung disease, neuromuscular weakness, pleural disease, chest wall deformity, obesity. And in mixed pattern, we will have both obstructive and restrictive elements. So how to identify whether it is obstructive or restrictive? And in obstructive pattern, the forced vital capacity will be decreased or normal, and FEV1 will be decreased for sure, because they will trap the air inside their lung, and when they try to exhale out the air, they will have difficulty. So FEV1 will be reduced for sure. Ratio will be confirmedly reduced, and lung capacity can be normal because they will have a higher residual volume in their lungs. They will do air trapping. They will not breathe out the volume, but their total lung capacity will be normal because expiratory volume is less, but residual volume is increased. So overall total lung capacity is normal or increased. They will have a barrel-shaped chest due to this. And in restrictive pattern, forced vital capacity is reduced because overall lung capacity is reduced. Then FEV1 can be normal or decreased because it is a rate. So rate will be normal, but total lung capacity will be reduced. So FEV1 to FVC ratio also will be normal in restrictive lung patterns. So how to diagnose? So one patient is coming to you, you are doing spirometry, and you are calculating FEV1 to FVC ratio, and if ratio is lower limit of normal or less than 0.7 or 70%, then if yes, then it is obstructive pattern. If no, then it is restrictive pattern or normal pattern. So we will first go on the left side of flow chart. If it is not reduced, normal ratio, then it can be restrictive disease or patient can be normal. So for that we will see the FVC, forced vital capacity. If it is not reduced, forced vital capacity is normal, then it is normal spirometry, the individual is normal. But if it is reduced, then that patient is having restrictive pattern. So is the total lung capacity known? And if yes, then is the total lung capacity less than the lower limit of normal? If it is yes, then quantitate the restriction using the total lung capacity as the percentage of predicted value. If it is no, then it is a normal test again. And we will come to right side of flow chart. For obstructive pattern, if the ratio of FEV1 to FVC is less than 0.7, then it is obstructive disease. Then next we will see how severe it is, and then if the forced vital capacity is less than the lower limit of normal, and if no, then it is pure obstruction. If yes, then is the total lung capacity is known. If yes, then is the total lung capacity is less than the lower limit of normal. Yes, then it is a mixed obstruction, and no, then it's a pure obstruction with pseudo restriction. So next test is body plethysmography. In this test, we can measure the residual volume and functional residual capacity, and with this if we include the spirometry, we can measure the total lung capacity. To test this, individual has to sit in a closed airtight chamber, and it can be difficult for the claustrophobic patient. The next test is diffusion capacity. This test estimates the transfer of oxygen in the alveolar air to the red blood cell. The factor that affect the DLCO is area of the alveolar capillary membrane, thickness of the membrane, driving pressure, and hemoglobin of the patient. So DLCO will be decreased when the area of the diffusion is reduced, like lung or lobe of lung will be resected, bronchial obstruction when the air cannot reach, and the interstitial pulmonary fibrosis. Second is when the thickness of the alveolar capillary membrane is increased, Then also DLC will be reduced. This happened in interstitial pulmonary fibrosis, congestive heart failure and pulmonary vascular disease. Then third is decrease the driving pressures in smokers and carbon monoxide exposure. And then reduce hemoglobin in condition like anemia and hemoglobinopathy. They will also have reduced DLCO. Then increased DLCO will happen in pulmonary hemorrhage, polycythemia, where hemoglobin is more, early congestive heart failure, asthma, exercise, obesity, and left to right shunts. Then this is another test, airway responsiveness. This is a test done for asthmatic patient. So asthmatic patient will have a obstructive pattern on spirometry, but that if that obstructive pattern can be reversible or not. If it is reversible, then it is asthma. If it is not reversible, then it is chronic bronchitis or emphysema. So after spirometry, we found out that patient is having obstructive pattern. Then we'll give 4 puffs of albuterol via spacer, and we'll do repeat after the 15 minutes. And to diagnose the asthma, there should be improvement in FEV1 or FVC by 12% or 200 cc. Note that both criteria should be fulfilled to diagnose. And normalization of spirometry after bronchodilator support is the diagnosis of asthma, and the lack of bronchodilator response does not preclude the clinical response to the bronchodilator therapy. So similar test were not advisable test, but here also we in previous test we were treating the cause, and here we are precipitating the asthma. So goal is to evaluate the airway hyper responsiveness in asthma, mainly allergic. So here technique we expose the patient with methacholine, histamine, cold or exercise, and criteria is reduction in spirometry FEV1 by 20% from the baseline. And then the test is positive. Patient is having hyper-responsive airways. Then this is another test, maximum inspiratory pressure, PI max and PE max, maximum expiratory pressure. The goal is to strengthen the strength of respiratory muscle, and technique is the amount of pressure the subject can generate during deep inspiration is PI max, and deep expiration is PE max. The normal PI max is -60 and PE max is +120 centimeter of water, H2O. And indication is neuromuscular disease like myasthenia gravis and unexplained decrease in vital capacity and mechanism. So, thank you.